Well, hello, everybody. It's such a pleasure to be here. However, I'm not an expert in education. I have absolutely no experience in teaching, and I don't do research. So what the hell am I doing here? I think Chris invited me to be your court jester. A slight embarrassment to you all, but with one thing going for me, and that's the benefit of survival, by which I mean a longevity in a role at the Lancet which gives me some perspective on the accumulated failures that I have witnessed and, in some cases, presided over, and the lessons to be learned from those failures. I want to tell you a story today about how we let success slip through our fingers and what we need to do to recover that success. Now, you don't need me to tell you that the world is changing dramatically, and I want to give just one example at the beginning of how the world is changing, and that's shown on this slide here. So we have total fertility rate, and we have 1950 to 2100. These are modeled estimates of total fertility rate, and you can see the way the curves have been split up is by region of the world. So you can see the global rate, that's the thick blue line here, and all of the lines are declining, as one would expect. But just look at how some regions of the world are going to change dramatically. We hear a lot in the media and from our politicians about the rise of Asia. But that rise of Asia is not going to be a long-term prospect. Demography is not always or totally destiny, but it certainly plays an important part in our fate as a world together. And if you look at the line for Southeast Asia and here, you see that there is, if I get the right line here, a very precipitous decline in total fertility rate. What that means is that the population of China is estimated to peak in 2064. It's currently around 1.3, 1.4 billion, but by the end of the century, it will have halved to 700 million people. The population of Japan will halve. And several other countries in the region of Asia-Pacific will also see dramatic falls in their population. The geopolitical weight that Asia-Pacific is certainly accumulating in the early years of the 21st century is unlikely to be sustained by the end of the century. And then if you look at Europe, Central Europe, Eastern Europe, you will also see declines. If you look at high-income countries, you will also see rapid declines. And what we're going to see in Europe is for countries such as Spain, Portugal, Italy, Poland, and many former Eastern European countries, populations once again halving. So the geopolitical weight of Europe by the end of the century will be considerably less than it is today. So which part of the world will take up the slack? The answer is that the future is Africa. If you look at the decline in TFR and you look at sub-Saharan Africa, you can see that although there is a decline, it's a decline on a much shallower curve. And if you look at where the share of live births are expected to be, again, on the x-axis looking from 1950 to 2100, and here looking at the share of live births, you can see that for low-income countries, many of which are in sub-Saharan Africa, the proportion of those total live births is going to increase substantially, quite explosively. The estimate is that we're going from roughly 1 billion people living in sub-Saharan Africa today to about just over 3 billion by the end of the century. 1 in 3 billion people on our planet will be from sub-Saharan Africa. So, if you only take one thing away from the next 40 minutes or so, it is this plea. You are a European association, and I respect that. You have a certain geographic boundary to your work. But in your next 32 years, please consider these demographic transitions, because you have an immense contribution to make to the future of children in the world, which is changing so extensively over the course of several generations. So can you expand your zone of geographic interest to anticipate the changes that are taking place in global demography? I'm sure you can. You're already an international group. It is not confined purely to Europe, but maybe I urge that you also turn your attention to Africa. I want to talk about this story, about success and failure. So let's start. How did we get here? Well, where is here? Here is that we have been part of a child survival revolution over the last 20 years. We've seen total mortality for children under 5 decline from over 10 million deaths in 2000 to under 5 million deaths in 2021. That is an unprecedented success story. A small contribution, but I think an important contribution, was made by the global science community who work on child health and child survival in particular. And I well remember in the early 2000s, a woman called Jennifer Bryce, a woman from New York with a brash temper, coming into my office and demanding to know what I, as the editor of a supposedly international medical journal, knew about child health. And the answer was, not much. She excoriated me for my ignorance and demanded that the Lancet publish a series of papers looking at the plight of children in the world and the opportunity to address the world's forgotten children. And that work culminated in a series of papers we published in 2003. And what Jennifer wrote in the final paper was, "We can wait no longer. Knowledge must be translated into practice. Millions of children will continue to die unnecessarily every year. Child survival is the most pressing moral dilemma of the new millennium." And she anatomized where the pressure points were for child mortality. This map shows a series of red dots, and every red dot represents 5,000 under 5 deaths. And you can see where they are concentrated. In fact, they're concentrated, although they're concentrated in parts of sub-Saharan Africa and South Asia, there are red dots pretty much all over the world. So this was a global challenge as well as having particular local contexts. After we published that series in 2003, experts who worked in neonatal health came to me and said, "Why haven't you talked about newborns, the first 28 days of life? That's important too." So we apologized and put together a series of experts on newborn health and published a call to action for newborn survival. And then, of course, all the people who worked on maternal health came to us and said, "Hang on a minute, you can't talk about the child without talking about the mother. So why haven't you put out a call to action on maternal health?" So we assembled a group of experts on maternal health and put together a series and a call to action on maternal survival. And then all the people who worked in sexual and reproductive health came to us and said, we're not talking about women just as vessels for reproduction. We need to think about the woman much more broadly. So why don't we talk about sexual and reproductive health in a much more holistic way? So we put together a group of experts in sexual and reproductive health, and we published a series on that with a call to action. And then, of course, those people who work on adolescence came to us and said, well, it's all fine saving children up to 5, but what's the point of saving a child up to 5 if you don't think about their life beyond the age of 5? We said, good point. So then we put together a series looking at adolescent health. And adolescent health, in their definition, was up to, it's really children and young people up to the age of around 24. Thinking of the adolescent period as a fantastic opportunity to make corrections for deficits that might have taken place in the early part of childhood. And at the end of all that, we realized, of course, that everything is connected. And the idea of dividing up the child from the newborn, from the mother, from the adolescent was totally fallacious. And by the mid-2000s, mid-late 2000s, this concept of the continuum of care was born, where we think about pregnancy running through birth, the newborn period, infancy, and there you can see all of it connected. And if we don't think of that continuum together, we're going to make major mistakes. What happened as a result of gathering all this evidence together and showing what interventions can do to reduce preventable mortality was that it gave confidence to political leaders to make women's and children's health a signature political initiative. We also learned something very, very important about science. And this, I really want to echo what Chris said on the very first day in her opening remarks, which I was so pleased to hear about. And that is, you're not just a scientific association, you also have political objectives. And that's the lesson I learned from these series, that data derived from the most reliable science can be a tool not only to monitor progress, but also to advocate for action and hold those with power accountable for their promises and commitments. We can use science as a political tool for social action. Indeed, that surely is a key responsibility that we all share. Now, this confidence that science gave to decision makers led Ban Ki-moon, who was the UN Secretary General at the time, to launch his signature health initiative, which was called Every Woman, Every Child, a global strategy for women's and children's health. And because the UN Secretary General was leading this, he was able to get the support of presidents and prime ministers from across the world. Stephen Harper is a conservative politician who was a prime minister of Canada, not known for his compassion in relation to deprived populations, but Stephen Harper stepped up and became one of the figureheads for gathering political support as a G7 leader, gathering political support for women's and children's health, together with more progressive politicians, in particular, Prime Minister Jens Stoltenberg, who was then the Prime Minister of Norway. So we had this incredible leadership from the top of the UN across G7 countries and elsewhere. The result of this leadership was that the floodgates opened for increased investment. In terms of new and additional funding in women's and children's health, we were getting around $20 billion extra dollars being invested where we didn't have that investment before. We also were able to adapt our approaches, our strategies to child health, again, based on the data. If you look at the causes of death of children under 5, of course, pneumonia is one of the commonest causes, but we were getting antibiotics to children, and pneumonia mortality was coming down. Similarly, with mortality associated with diarrhea. The provision of vaccines for children was a major contributor to reducing under 5 mortality. But that success story meant that, as a proportion, the number of deaths in the newborn period was rising from around 30% up to present times almost 50% of deaths in children under 5 are now confined to that first month period of life. So we were able to adapt our approaches based upon the data. And this, of course, was the power of data to influence the politics. A complicated slide, but let me just emphasize again how important data can be in defining our priorities. Here you have interventions across the antenatal period, care during labor and childbirth, in the immediate postnatal period, and the different interventions: tetanus toxoid, insecticide-treated bed nets, syphilis detection, antenatal care, steroids in preterm labor, antibiotics for premature rupture of membranes, skilled birth attendants, and so on. And we were able to get data looking at coverage. So here we have percentage coverage for each of these interventions. So for some, we were doing well. Tetanus toxoid vaccination up to almost 70%. But there were other areas where we were doing very badly. 11% for clean postnatal practices. 8% for oral biotics for neonatal infections. So again, we were able to much more precisely target where those extra billions of dollars should be spent on certain commodities to get to children to save lives. It was a virtuous relationship between data and politics. We were also able then to model where should we be giving these interventions. Should they be given in hospitals, in primary care facilities, or the community? And knowing all of those interventions and the impact they would have, we could see that if we divided up interventions into community, primary health care, and hospital, the child health package in the community would have a huge impact. This is the number of deaths averted, so close to 1.4 million deaths averted through a child health package of interventions delivered at community level. All of this information gave enormous hope to our prospects for success and contributed to that halving of child mortality. And so when a group of us tripped along to New York in 2015 to mark the end of the period of the Millennium Development Goals and the birth of the Sustainable Development Goals, on every single position where we sat in the General Assembly, this was the sign that was in front of us. It was judged that the MDG period had been a phenomenal success. And for children, I think that was entirely justifiable. So where are we now? We started off well. We started off well because we had a clear strategy for what we wanted to do. We wanted to go beyond survival. So the global strategy for women's, children's, and now adolescent health was about survive, thrive, and transform. And in the thrive bit, that included education. We were immensely hopeful about what could be achieved based on the 15 years of success with the MDGs. We published a commission in 2013 looking at prospects for the SDG period. And the basic message was that this blue line is for low-income countries, the purple line is for lower middle-income countries. 2011 out to 2035, under 5 mortality. And what we were arguing was that we had the knowledge to be able to take low-income country, under 5 mortality, and bring it to convergence with countries that were richer, more developed than those low-income countries. We really could achieve something that had never been achieved before. For the first time in human history, we had the prospect of eliminating all preventable maternal and child mortality. We modeled that, and so this is the top modeling line here is looking at if you just had observed country-level rates, so if we basically just continued on the path that we were going on, but these were more hopeful lines of what we could achieve. Now look, I showed you at the beginning 4.7 million child deaths in 2021. So if we look there, 2021, and we go up here, 4.7, that's about here. So actually, we've done pretty well to get to where we were in that child survival revolution. But it's not the same for every part of the world. These are aggregates, these are averages, and behind those averages lie some pretty unpleasant realities. So here again, we're looking at from 1990 forward, this time to 2130, and looking at newborn mortality. This curve, the blue dotted line, is showing what the likely rate is going to be for newborn mortality for sub-Saharan Africa. And the basic message is that we're only going to get to rates of newborn mortality comparable with countries in high-income settings by over 2120. It's going to take 110 years for Africa to reach where we are today. That is unacceptable at every single level. And this is why I say, as I said at the beginning, the future is Africa demographically, and the future must surely be Africa in terms of our priorities. We're also missing out a whole group of tragedies which, again, are almost always preventable, and that is stillbirths. There are close to 2 million stillbirths every year. That works out at 1 stillbirth every 17 seconds. We don't talk about stillbirths. It's hidden, it's stigmatized, and it's not on the global child health agenda at all. It should be, it must be, stillbirth deaths should be part of that 4.7 million. And if you add it, it's close now to 7 million deaths a year. And we should be adding stillbirths to our thinking. That should be part of our agenda. Now, you heard mentioned in the previous keynote, Dr. Tedros, Director General of WHO, is a very fine leader of that agency and did the best job he could during the pandemic. At the beginning of his first term, he argued the new mandate for the World Health Organization was that all aspects of health should lead to universal health coverage. And he's absolutely right. However, in the MDG era, we had MDG 4 and MDG 5, which focused on child health and maternal health respectively, and oriented political commitment to saving children's lives and saving the lives of mothers. The trouble with universal health coverage is, as absolutely right as it is, it's about an abstract concept and not a human being. In the first keynote, I thought it was beautifully captured. Imagine a child is with us in the room. You can't imagine there's a universal health coverage in the room. And so if you're a president or a prime minister, are you really going to invest your time and your money with a skeptical electorate into UHC? And the answer is no, they have not done so, and that's why we're now falling behind. Because the unpleasant truth is that momentum on child health, on maternal health and women's health more generally has completely stalled. We have no high-level political leadership. Not one political leader in the G7 and no other political leader across high-income countries has stepped up to lead on women's and children's health. We have no high-level UN leadership. The Secretary General of the UN, Antonio Guterres, again, has done many good things, but he dropped every woman, every child. It wasn't going to be his signature global health initiative. Dr. Tedros, every department at WHO now doesn't lead on the human being at the end of the disease, whether it's a child or whether it's a mother or a woman. It's all around universal health coverage. We have a distracted and indeed weakened WHO. After COVID, although I think Tedros did the very best he could in unbelievably difficult international circumstances, WHO has been weakened politically by the impacts of Trump and others in criticizing both Tedros and the work of the agency. It's a much more competitive financing environment. We have the Global Fund to fight AIDS, TB, and malaria. We have the Global Alliance on Vaccines and Immunization. We have a new pandemic fund. There isn't enough money in the world now to go around to spend on all of these health initiatives. And so whereas we had our focus in the MDG era on women and children, now it's distributed across many different areas, and that has, again, weakened our sense of possibility for what we can achieve. The result is that we have softened advocacy and weakened accountability. And we're living in an era of de-development. The pandemic increased by many tens of millions the number of people living in poverty. And we've not been able to claw that back. The climate crisis is exacerbating those impacts. So perhaps we need to pause and stop doing what we're doing, because what we're doing currently isn't working. Perhaps we need to reframe our approach to the health of women, children, and young people. So that brings me to the final part of what I'd like to share with you today, and that is, where might we go in the future? We're not doing this at the moment, but this is a possible way forward. You've heard a lot about the idea of a public health emergency of international concern that WHO can issue when there's a pandemic. Or when you have 4.7 million under 5 deaths, almost 2.5 million newborn deaths, and over half of those are in sub-Saharan Africa. And when you have still almost 300,000 maternal deaths, 70% of those in sub-Saharan Africa, almost half in just 6 countries in sub-Saharan Africa, is that a public health emergency of international concern? The answer is yes, of course it is. And if you look at where we are today, we're in a terrible place. Over 50 countries will not hit their 2030 target for under 5 mortality. More countries, 60, will not hit their SDG newborn mortality target. And for maternal mortality, to hit that target, you'd have to have an 11% reduction in mortality every year to get to 2030. That ain't going to happen, because it's never happened before. So we absolutely have a public health emergency. Why are we not saying that as a community? Why are we not proselytizing that message? We're not angry enough. We should be raging about this failure. Perhaps in the reframing, we do need to resituate our approach to children and young people in a different way. For example, if you reframed child survival in the context of the environment, 1.7 million children die every year because of a polluted environment. This message came out of WHO, but it didn't come out of the child health part of WHO. It came out of the environmental health part of WHO. And we in the child health community have been far too slow to pick up this message about the role of the environment in shaping children's futures. Now, we tried with a Lancet commission to kickstart this reframing. And so we went to WHO and Dr. Tedros, and we went to UNICEF, and we said, could we work together to really rethink the way we devise a plan for the future of children? And we wanted to do it in the context of balancing two issues: the flourishing of children and the sustainability for children. And here we are in Geneva. There you can see Dr. Tedros. Next to Dr. Tedros on his right is Helen Clark. She was a co-chair of the commission, former Prime Minister of New Zealand. So we managed to get high-level political commitment around this commission. And it was a fantastic launch, except, look at the date, February 2020. Disaster. Because within weeks, in fact, at the lunch before we launched the commission, all Dr. Tedros was talking about was the impending pandemic that was coming out of China at the time. So the commission died almost as soon as it was launched because other issues took over. But it's still worth looking at this, at the core message that we were trying to promulgate, because we can revive it. So we wanted to balance flourishing with sustainability. For flourishing, the measure of success for any country was this division between survive and thrive. So we constructed a flourishing index. For survive, we included measures such as child and maternal mortality, and for thrive, measures around learning and education. And when we constructed the flourishing index, this is the flourishing rank, so we ranked countries. So you can see here the US came 39th in terms of flourishing, Australia 20th, Luxembourg 11th, Canada 21st. But then we wanted to say, well, that's all very well. Maybe these countries are doing quite well in terms of flourishing, but how are they doing on sustainability? And the sustainability index we constructed was based on carbon emissions. And then when you looked at carbon emissions next to sustainability, of course, you get a very different story. And this is the sustainability rank, and we looked at 180 countries, and so you can see we're starting off with the worst country in terms of sustainability, Qatar. Although it was 54 on flourishing, it was bottom of the table on sustainability. The US, 39th on flourishing, but close to the bottom on sustainability. So when we think about progress for child health, we shouldn't be doing it without also balancing that progress against a measure of sustainability, which is the context for that child growing up. This was the argument we were trying to make, the paradox between flourishing and sustainability. Can it be revivified? Well, I think there's a possibility. In August, just last month, UNICEF launched this report looking at the effects of the climate crisis on the future of child health and well-being. And they began to do some of the things that I've been talking about, looking at the impact of climate on child survival and taking a continuum of care point of view from the mother through the child as the child grows up into a young person, and trying to look at the effects on pregnancy, malnutrition, and so on, all the way through to adolescence. this is part of the reframing we need to do. But there are other issues we need to bring into this reframing as well. We live in a very dynamic situation. If you look at the double burden of malnutrition, for example, two measures, thinness for height and overweight. And you can see that this double burden is now becoming a real public health emergency. Because overweight children under 5, close to 40 million, 5 to 19, 160, 20 plus 880 million. That means that we have 1 billion children and young people, 1 billion children and young people who are now overweight. No country in the world has devised a successful public health program that is bringing that burden down. The commercial determinants of health are now becoming a growing and more important force shaping the future of children. We published a series last year looking at the impact of breast milk, formula milk manufacturers, and how they are using their marketing methods to deliver misinformation, indeed disinformation, because it's deliberate, shaping the decisions of new mothers. There's an interesting group of children, again, who are completely marginalized in thinking about their future. Rolling out antiretroviral programs to address vertical transmission of HIV has been a fantastic success story. But there are now 15 million children in the world who are HIV negative but have been affected by their mother having acquired HIV. We don't fully understand the biology of it, but we do know they have been immunocompromised, so they're more at risk of infections, and there are cognitive and neurodevelopmental changes in those children which are significant. So 15 million children who have been HIV exposed but uninfected is a really, really key group to think of as we're thinking about child development and education. Again, we can't think about children without thinking about the context of the mother. And I just want to draw attention to the issue of women's place in society. So if you divide our mortality rate in children according to women who are judged to be highly empowered, medium empowered, and low empowered, you can see that the mortality rate in the more empowered communities is lower than in the less empowered communities. So unless we try and address the disparities for women in our societies and make gender equality an absolutely central focus of our concern for child health, we're not going to succeed in our concern for child health. Gender equality goes absolutely hand in hand with our work in child health. And the child health community, by and large, the community I work with, I don't mean you, the community I work with, largely has ignored dimensions of gender equality. Racism is an appalling but central force, again, in shaping the future of children. 2 years ago, we published a theme issue on racism and health, and one of the articles we published was looking at the causality of how racism influences perinatal outcomes. And in the context of our discussions today around immigration, and frankly, the racist comments that now seem to have become normalized in our political discourse, we should have reason to be concerned about the impact on child health. And you and I need to become active anti-racist campaigners in society. This cannot be left to others. This is our responsibility. If we claim to be interested in child health, We have to be on the front line of anti-racism campaigning. And I can't not also talk about the impact of conflict on children and women. This, looking over the course of the past decade up to 2017, the impact of children and women displaced by conflict. And I don't need to mention the name of any particular conflict today in the world because there are too many and they're all over our television screens and our newspapers and our social media. You know that women and children are the first to bear the brunt of health harms in any conflict. What are we doing to advocate for women and children in those settings? So to conclude, what's the answer? And I think this is where this message about transdisciplinarity perhaps resonates with where I'm trying to go. We need to think about the continuum of care from preconception to adolescence. We need to think not just me in the health community, but I need to think about the nutrition community, safety and security, education and relationships. And they're not just about a health system, but about much broader range of issues around families, communities, services, policies, economics, sociopolitics, and climate. I don't know whether the nurturing care framework is the right phrase for this, but it is to recognize that we need to step outside of our fields, our disciplines, our silos, and find ways to work together, and that's certainly my commitment with Chris and all of you. I want to end. Please read this book. It's a wonderful book by somebody who's written most of his work in Spanish, but he wrote this book in English just a year or so ago by Jaime Braille, and it's a book that he writes about critical epidemiology. And this quote, I think, is so powerful. The movement of emancipatory knowledge needed to explain, mobilize, and transform society, and not merely describe its fragmented causal conjunctions. Let's stop describing the problem. Let's think about how we use our knowledge to emancipate children and women in the world today. That's your mission. That's my mission. Let's do it. Thank you.